Hello everyone, continuing with the quick review series. Today we'll be discussing in a nutshell about the management of alcoholic liver disease. Now, alcoholic liver disease is the spectrum of disease. I will not be discussing in this lecture about the pathogenesis or pathology. I'll be just focusing on the management part. So, the spectrum of alcoholic liver disease, you must have studied in the pathology also that it starts with steatosis. Steatosis, most likely it is the macrovesicular steatosis, then steatohepatitis, hepatitis, and in the end it comes the fibrosis or cirrhosis. This fibrosis is of course the chicken wire pattern of fibrosis. We'll be discussing on this portion in the separate lecture, not in this lecture. Chicken wire type of fibrosis, and fibrosis starts from the perivenular area, the zone 3. If you know about the histology of normal liver hepatocytes, then you must be knowing the zone 3 is something which is around the central vein. And the fibrosis in case of alcoholic liver disease starts from that region. So this is the spectrum. Starts with steatosis, macrovesicular steatosis, then steatohepatitis, then the fibrosis or cirrhosis. Now for this steatosis and steatohepatitis, what is the management? Actually, these are reversible conditions. Up to steatohepatitis, it is reversible. The only thing that we need is alcohol abstinence. We need alcohol abstinence. Of course, for alcoholic hepatitis, the pure alcoholic hepatitis part, we have some drugs that I'll be discussing in the next slide. But remember, steatosis and steatohepatitis, they are reversible with alcohol abstinence. But once cirrhosis sets in, this is irreversible, of course. So for this, what you need to do is you have to give treatment like any other cirrhosis, any other case of liver cirrhosis. You have to give the treatment. You have to do SCC screening, hepatocellular carcinoma screening 6 monthly. And if there is SCC, if there is decompensated chronic liver disease or cirrhosis, then you can go for liver transplant. But in many of the alcoholic liver disease cases, liver transplant is quite difficult because of the institutional protocol that they follow, that the patient should be in abstinence for at least 6 months. Then only they take for transplant. So in usually in patients with alcoholic liver disease or CLD, getting abstinence of 6 months is really difficult. Okay, so this is the overview. But what we are really want to discuss in detail is about alcoholic hepatitis. Okay, so we'll be discussing in detail about the treatment of alcoholic hepatitis. But before that, what are the scores that we should be familiar with? The first score is MELD score. MELD score. MELD score and child Cook score, they are mostly used for this chronic liver injury, mostly for chronic liver disease. But MELD score can also be used in case of alcoholic hepatitis to make a decision regarding the management. So MELD score, you just need to remember what are the components of it. So components are CBI. So this is creatinine, this is bilirubin, and this is INR. Creatinine, bilirubin, and INR. Then second important point is MADRS discriminant function, MDF score. This is MADRS discriminant function. This is calculated by this formula 4.6 into delta PT plus the serum bilirubin in milligram per deciliter. So what do you mean by delta PT? Remember, in patients with liver injury, PT will be prolonged. So patient PT, prothrombin time of the patient, minus the control PT. That is delta PT. So the formula is this 4.6 into delta PT plus serum bilirubin. Okay. So these are the two important scores that you have to remember in the context of alcoholic hepatitis, because they will help us guiding the treatment, drug therapy. Apart from that, what other score you can calculate here is ABIC score. ABIC score. This is albumin, bilirubin, INR, and creatinine. Very simple. Albumin, bilirubin, INR, and creatinine. This score also can be calculated. Now coming to the algorithm for management of alcoholic hepatitis. So once the diagnosis of alcoholic hepatitis is confirmed, you have to calculate the MELD score and MADRS discriminant function. These two score you have to calculate for a case of alcoholic hepatitis. So usually in alcoholic hepatitis, the AST levels will be raised up to 200 to 300 in that range, and most of the times the ratio of AST to ALT, most of the times it is more than 1.5. Okay, and the this values of this AST and ALT usually within the range of 200 to 300 or 200 to 400, not in thousands. Okay. Anyway, more on that I'll be discussing in separate lecture. I'm just focusing on the management part. So once alcoholic hepatitis, you have made a diagnosis of alcoholic hepatitis, then you calculate the MELD score and MADRS discriminant function. Now, if MELD score is less than 20 or MADRS discriminant function is less than 32, MELD score is less than equal to 20 or MADRS score is and MADRS score is less than 32. This is a case of moderate alcoholic hepatitis. In this case, you just give supportive management and alcohol abstinence. Alcohol abstinence and other supportive management you can give. But if MELD score is more than 20 or MADRS discriminant function is more than equal to 32, this is or. So any of this, if any of this is fulfilled, either MELD score is more than 20 and MADRS discriminant function is more than equal to 32. I hope you can clearly see that it is for MELD score it should be more than 20. That means either 21 or more. But for MADRS discriminant function is more than equal to 32. That means either 32 or more. So if anything is there, then this is actually severe alcoholic hepatitis. This is severe. So here we have to give drug therapy. Okay, here drug therapy is approved. So what is the treatment? Treatment is steroid. So steroid you have to give prednisolone. If the patient is able to take orally, give prednisolone 40 mg OD. 40 mg OD. If the patient is not able to take orally, you can give IV methyl prednisolone. IV methyl prednisolone 32 mg IV OD. Okay, so this is the drug therapy that has to be given. Of course, there should not be any contraindication to steroid therapy. You all must be familiar with the contraindications of steroid therapy. This is very important. Patients should not have uncontrolled bleed. So my upper GI, significant upper GI bleed, UGI bleed is a contraindication. Any kind of infection or sepsis or multi-organ dysfunction, shock, all these things are again contraindications. Renal failure, AKI, acute kidney injury, or hepatorenal syndrome, these are also contraindications. Apart from that, associated conditions like tuberculosis, HIV, other viral infections like hepatitis B, HBV, HCV, etc. So if these associated conditions are there, so you will not be able to give prednisolone. So these are the contraindications. So if these things are there, you cannot start with prednisolone. You have to just continue the supportive management. You have to treat those conditions, and then you can think of giving steroid. Once you start steroid, you assess the response at day 7. Day 7, response is assessed by Lilly score. You need not know about the details of Lilly score, that is not important. You just need to know the value. If it is less than 0.5 or it is more than equal to 0.45, less than 0.45 or more than equal to 0.45. If it is more than equal to 0.445, that means patient is not responding to steroid. It's non-responder, that is known as non-responder. So Lilly score is used to assess the response of this kind of patients to steroid, of patients with alcoholic hepatitis steroid. If Lilly score at day 7 is still more than 0.45, they are known as non-responders. You have to stop steroid, stop steroid, because they are not responding. It will be more detrimental if you continue the steroid. For those patients, either you can go for early liver transplant, but as I told, it's not usually feasible in most of the situations, or you can just give supportive and palliative care. So supportive therapy. If it is less than 0.45, that means the patient is responding. So these are the responders. So you can continue continue the therapy. Steroids have shown to reduce the 28-day mortality, 28-day mortality, but not the 6 monthly mortality. So steroids have shown to reduce 28-day mortality, but not 6 month mortality. It's not 6 month mortality. This is important. Now this is the drug therapy, but what are the other supportive therapy you should give? You have to give enteral feeding. Whenever possible, you have to give enteral feeding. And the amount of calorie that you have to give is more than 21 kilocalorie per kg. Which micronutrient should be provided? It is zinc. Which vitamin should be provided? It is vitamin B1, thiamine. You all must be knowing that alcohol causes severe thiamine deficiency. So thiamine has to be, of course, you can give multivitamins, but the most important one is thiamine. And among the micronutrient, it is the zinc supplementation that is important. And all these patients will have a hypoalbuminemia because of liver disease, and so that's why you can give albumin, IV albumin as volume expander. IV albumin as volume expander. That's a quick review of management of alcoholic hepatitis. Thank you so much for listening.